So the session we're at today is what to do with the nodule. And I know that there's a majority of surgeons in the room, but I will try to convince you that you should let me zap this nodule. Here is my conflict of interest. So what to do with the nodule? We should not make this decision arbitrarily, but unfortunately, we do not have good phase 3 randomized controlled trials to guide our decisions. And so when faced with this question and a patient, we should go to the next best available level of evidence. So I'll walk you through a few questions and a few key points to keep in mind whenever we're trying to decide should the nodule be irradiated or operated. So the first question is, if we go with either treatment, will we get a better local control? So what we know is that actually SBRT for stage 1 non-small cell lung cancers is actually associated with a very high local control rate. For tumors that are not central and less than 3 centimeters, we're talking about over 90% local control. Ultracentral tumors, so those that are within 1 centimeter of the proximal bronchial tree or of the esophagus, pose more of a problem. And as radiation oncologists, we've always been a bit more concerned about those nodules because we know that the proximal bronchial tree, the esophagus, are quite sensitive to radiation, and we can run into issues of fistulas and hemorrhages if we are not careful. But more recently, with advances in SBRT techniques, we have been able to improve local control rates even for those tumors. And so more recent data report about 78 to 88% local control rates at 2 years for those nodules. And there's a recent retrospective data analysis with propensity score matching that I'll be mentioning a few times today that was just published in 2024. And in that study, the local control rates between SBRT and minimally invasive lobectomy were felt to be similar. So that's for local control. Now, what about regional and distant control? So we know that SBRT tends to have higher rates of regional and distant recurrences compared to surgery. So if I show you here, this is that propensity score matching analysis of 2024 I was mentioning. So for regional recurrences, we can see definitely that it's higher with SBRT in the order of 18% at 5 years versus 14% for surgery. And distant recurrences are also higher, so 26% versus 20% at 5 years. So it is higher. But is that surprising? Not at all. So we know that the omission of pathological nodal staging contributes to understaging of about 11 to 18% in clinical stage 1 patients that are staged with PET. And what does that mean? Well, actually, if we understage our patients, well, we undertreat them. The reported rates of post-op adjuvant therapy in patients undergoing surgery for stage 1 non-small cell lung cancers are in the order of 11 to 22.6%. And we know that if we do SBRT, we won't be knowing about the presence of occult nodal disease in the mediastinum. And overall survival, so between SBRT and surgery, is overall survival truly higher with surgery than with SBRT? Well, actually, so we have some retrospective studies using propensity score matching that suggest similar overall survival between the two. And there's a recent prospectively collected cohort analysis of long-term survivals for non-small cell lung cancers less than 2 centimeters that show that the cancer-specific survival is high for both treatment and not statistically significantly different, and that also the overall survival after propensity matching was not statistically significantly different between the two. So we've talked about the outcome of the nodule itself, but what about toxicity? So surgery has a worse toxicity profile. So again, this is from this 2024 propensity score matching analysis. So the rate of grade 2 or higher complications reported is about 33% for the surgical cohort as compared to 12% for radiation therapy. And the 30-day mortality after the procedure for lobectomy, even minimally invasive procedure, is about 1 to 3.7%. After SBRT is quite low, 0 to 0.2%. And when we think about toxicity, so this is for all comers, but there are specific populations of patients that we should pay extra attention to. So I'll mention a few of those populations of patients. So first of all, patients with interstitial lung disease. So this is a heterogeneous group of diseases characterized by abnormal gas exchange. But they are not all the same. Interstitial pulmonary fibrosis is actually associated with a worse prognosis as compared to the other ILDs. And there is a score, the ILD Gender Age Physiology score, so ILD GAP score, that actually gives an idea of the mortality that is associated with the ILD itself. And so basically this divides the different categories of ILDs. And we can see that for the highest score patients, the mortality at 1 year can reach 33% just from the ILD itself. And unfortunately, for many of the ILD patients, even with an early stage non-small cell lung cancer, surgery might not be an option because of the pulmonary function tests. And when they are candidates for surgery, they typically have higher rates of post-op complications. And up to recently, radiation therapists were also quite concerned about giving SBRT to patients with ILD because the rates of grade 3 or higher pneumonitis in this population of patients in retrospective studies has been quoted as high as 30%. But thankfully, we have a new study from this year, ASPIRE, that is a phase 2 study of SBRT, 50 grays and 5 fractions, for patients with T1 or 2 N0 non-small cell lung cancer and ILD. So they recruited 39 patients with a median age of 78 years old. Most of those patients, so 80%, had T1 disease. And the majority, 82%, had symptoms at baseline from their ILD, and even up to 15% of the patients in this study were on home oxygen. And one thing to mention, though, about the study is that only 2 patients in this cohort, so 2 out of the 39, had a high GAP score index of 6 or more. And after a median follow-up of 19 months, they report a median overall survival of 25 months. They found no significant difference in survival based on the GAP score index. But what they did find was that they had worse overall survival for different kinds of ILD, so notably interstitial pulmonary fibrosis, as well as chronic collagen disease associated ILD. And the local control at 2 years was 92%. And the rate of grade 5 toxicity, so of patients dying following their treatments, was 7.7%, so 3 out of their 39 patients. And those 3 patients had the highest risk type of ILD. So the conclusions of this study is that overall survival and toxicity was actually better than previously reported for this population, and that SBRT with 50 grays and 5 fractions should be offered after careful discussion with patients of the risks and benefits. My grain of salt in this study is that with only 2 patients with a GAP score of 6 or more, we should be quite careful in offering SBRT to those patients. So we've talked about toxicity in the general population and toxicity for patients with ILD. Now the elderly patients. So this is another type of patient that we need to pay special attention to. So we know that we can have 2 elderly patients in front of us that are independent, and one of them, after a minor illness such as UTI, might decrease a bit their level of functioning, but will be able to go back to their baseline level. Whereas some other patients that are independent and elderly, after a minor illness, might have much more functional disability and not be able to go back to their baseline level. And we think of side effects of treatments, so post-op complication, but also chronic rib pain following SBRT or other side effects of treatments could really impair those patients and have a long-term effect on them. So there is the J questionnaire that I invite you all to get familiar with. It's a 4-minute questionnaire that basically encompasses a lot of questions we typically ask to our patients in clinics, such as if they've lost any weight recently, their mobility level, how many meds they take. And so with this questionnaire, we're able to identify patients that would benefit from a comprehensive geriatric assessment. So it's a 4-minute questionnaire with mostly questions we already asked. That's quite worth thinking of doing in our patients that are elderly. So what do we know about treatments for elderly patients for early stage non-small cell lung cancer? Well, there's a study from 2011 that did a match pair comparison of 120 patients that were over 75 years old with stage 1 non-small cell lung cancer that were either treated with surgery or SBRT. They were matched by age, stage, gender, and treatment year. And not surprisingly, the 30-day mortality after surgery was higher than the 30-day mortality post-SBRT. It reached 8.3% in this cohort. And there was no overall survival difference. Now, there's a more recent study that I wanted to point out here. So from 2022, that basically suggests that surgery is better for elderly patients. But then when you look a little more into this study, so it's a matched pair comparison of 372 patients over the age of 79 with a stage 1 non-small cell lung cancer that were treated with either surgery or radiation. But actually they acknowledge not all radiation was SBRT, not all radiation was necessarily radical. And so they match patients by age, sex, race, year of diagnosis, tumor size, histology, pathological grade, and they were using the SEER data. And what they tell us is that, well, basically this is the overall survival curve, and in red is radiotherapy, so radiotherapy is worse in those patients. But actually, when you look a little bit more into the article, you see that there was no difference in overall survival and cancer-specific survival between surgery that did not remove any lymph nodes and radiation therapy. And they also acknowledge themselves in their article. So as we know, there are significant survival differences between conventional radiation and SBRT, which may be one of the reasons for the survival advantage of surgery to radiation therapy in our study. So just a little note to be careful when you see abstracts of study and to look a little bit more. So for elderly patients, we should be careful and assess them properly before offering a treatment. And this study I found was quite interesting. So having SBRT available at your hospital might actually help you improve your surgical outcomes. So this 2022 study used data from over 200,000 patients who underwent surgical resection for an early stage non-small cell lung cancer from 2004 to 2015. And they saw that there was a lower post-op mortality rate when surgery was done at a facility that also offered SBRT. And the outcomes were further improved at a facility that had a longer duration of SBRT experience and a greater SBRT to surgery ratio. So this was also statistically unrelated to other measures and confounders. So these are the general principles that you should think of when you're wondering if you should irradiate or operate your patient that is in front of you with an early stage non-small cell lung cancer. Now I'll just spend the last few minutes talking a little bit more about the diagnosis and the staging. So for nodal Mets, we know that the scan of the chest is not a reliable way of assessing nodal Mets. It's considered that the node is suspicious if it's over 1 centimeter, but there's many benign etiologies that can exceed that threshold. The sensitivity is around 55%, specificity around 80%. And PET scan is actually much better at assessing nodal Mets with a sensitivity of around 80%, and this can actually vary between scanners and histologies. And as we mentioned earlier today, the indications for invasive nodal staging for N2 nodes are tumors that are 3 centimeters or over, central tumors, and any positive node on PET scan. But these guidelines are actually being challenged by some authors. So there's a study from 2020 by Ducombe that reported rates of 8% of N2 disease in tumors that were less than 3 centimeters. And in her study, there was no difference with the nodal Mets according to the distance from the carina. There's also another study from Gao and his team that reported rates of 6% of N2 disease in tumors that were between 2 to 3 centimeters. And there's also a few other studies that challenge the concept of the risk of N2 disease being higher for peripheral versus central tumors. And we have those studies questioning the current guidelines for invasive mediastinal nodal staging, and some answers to those are that actually up to now studies have not shown a difference in recurrence or survival outcomes in patients that undergo SBRT with pretreatment invasive mediastinal staging compared to those who do not. But those are all retrospective studies with patients undergoing invasive staging because they were at higher risk of nodal disease. And also in those studies, the patients that underwent invasive mediastinal staging had a longer time from diagnosis to treatment. So for the moment, we should still stick to the current guidelines, but we should keep in mind that our patients that do not fill the guidelines for invasive mediastinal staging can have higher rates of nodal Met, and this should also be discussed with patients, and it could be in the range of around 6 to 8%. A final word on the diagnosis and staging. So to keep in mind that delays in treatment initiation, whether it's surgery or radiation, can have a negative impact on patients. And it's reported that restaging should be considered after 8 weeks of delays, as rates of progressions in the rate of 12% are reported, and rates of even stage change of 6% are reported after 6 weeks. So to conclude, how to choose? Well, both surgery and SBRT have their place in the treatment of early-stage non-small cell lung cancer, and both have their limitations. So surgery, even when minimally invasive, is associated with non-negligible morbidity and mortality rates. And in patients with ILD, in patients that are elderly and frail, the risk-to-benefit ratio should be kept in mind, and having honest discussion with patients is really paramount. And SBRT, although locally effective, can result in undertreatment of patients because of occult nodal disease. And we have some studies underway looking into giving immunotherapy in conjunction with SBRT, and results will be helpful to guide our treatments in the future. And having both options available and discussed to our patients is really a key to success. And we have some phase 3 randomized controlled trials that are currently accruing and that are underway, VALOR, stablemates, and that might help guide these discussions in the near future. Thank you.
Thank you. Of a 78-year-old gentleman with a 1.5 centimeter growing nodule, PET avid with no adenopathy. What should we decide?
So, well, there's much more information that we'll want to see, right? So what kind of 78 years old is that patient? Where is it located? But definitely, SBRT will always be an option.
So the patient can have two options, meet with both of you, and then decide based on...
I love that. I love when they meet with both of us. And I think that whatever decision they take, when they meet both the surgeon and the radiation oncologist, there's no questions later on. If they meet with both of us, they decide for surgeon, they have a complication. Well, they met with me before they knew the option. It's hard to say, well, I didn't know that there was another option, and how come I have this complication that I'm stuck with? And vice versa. If there's, they go with radiation therapy and they have any questions later, well, why wasn't I operated when my friend my same age was operated? They met with you.
No, I agree. I think surgery is a good option, SBRT is a good option, and shared decision-making is the way to go. Easy question, Jason.
Thank you, Magali.
Thank you.